There's a dirty secret in pelvic health, and you already know what it is. If you're a pelvic clinician and you are plateauing in these complex cases, then this is going to be relevant for you. Now, I brand myself as a pelvic health specialist, a pelvic floor physical therapist. But if all I do is treat a pelvis, I will have missed most of the opportunities to help someone. Siloing treatments to just the pelvis is a problem. And that statement is a bit controversial in our field, and it should not be. Now, stick with me. There's a specific clinical move I'll get to that'll help you handle your next plateau. Pelvic floor work is orthopedic work. Orthopedic work is pelvic work, and we have to treat the whole body. Now, I treat men with pelvic floor problems all the time and have done so for a long time. And I say this to you because it's just something I've seen for coming up on now decades of practice. Siloed treatment doesn't work. Sorry, sorry, but it's true. I see this as a big problem in pelvic floor specialization. For example, if I called myself a shoulder specialist, that's what I did. And every patient that came in, I did a detailed, thorough examination of only their glenohumeral joint. And I only treated the glenohumeral joint. What would my outcomes be as a shoulder specialist? Terrible. This is not revolutionary. Okay, fine. Calm down, Chad, calm down. What if, instead of only treating the glenohumeral joint, I only treated just the scapular and shoulder girdle? So I got glenohumeral joint, I got acromioclavicular, I got sternoclavicular, I even optimized the scapula. Woo! That shoulder complex is moving perfectly. If I only treated those things I just said, what are my outcomes going to be as a shoulder specialist? Now, I can go into a conference for ortho, manual therapy, and talk to a bunch of shoulder people, and I can say that. And it may ruffle some feathers here and there, but deep down, I haven't really caused a controversy. They know. They know that, just for example, if the thorax is rotated or dysfunctional, or there's a rib dysfunction, I can make that shoulder complex beautiful and perfect. But if I haven't addressed the foundation that shoulder sits on, in this case, the thorax, I will never optimize that shoulder. I just won't. That patient will never fully recover. So that seems to be okay in some areas of manual therapy, physical therapy. When I go to these conferences for pelvis, unfortunately, and this may not be such a popular thing to say, all we talk about is the pelvis. And to the credit, oh man, some of y'all are outrageously knowledgeable about pelvises. It's incredible the amount of knowledge. And we go and we talk about conferences and treatments and this nerve and that muscle and that ligament and that tissue and this condition. And we're just so excited about the pelvis. And that's okay. It's new for now. But we fail to zoom out. We fail to remember that the pelvis is just part of a system. And just like our shoulder situation, if all we talked about for shoulder rehab is nothing but shoulders, our patients will not have good outcomes. And right now, in pelvic floor PT, at least from what I've seen, all we like to talk about is pelvises. And we're missing the big picture. We're missing the forest from the trees. Second point here, newer clinicians. Oh, I'm with you. Newer clinicians will do a technique. The patient will feel a bit better. That clinician feels like a superstar. They did something, an intervention that caused a positive response. The patient, oh, that does feel better. Thank you. And man, does that feel delicious, right? We are in the job of helping people. And when we do something that helps somebody, I got it. Rinse, repeat, do it again, do it again, do it again. It worked until there's a plateau. Oh man, plateau. What a dirty word, eh? There's a plateau. The patient has gotten a bit better, but they'll tell you something like, well, after the last session, I did feel a bit better for a few hours, a day or so, and then things did kind of come back. But and then your patient apologizes for you and gives you a help. But don't worry, clinician, it's okay. I think we're making some good progress here. Can we do that thing again? That helped for a little while, and oh, what a relief! It helped for a little while. Thank you. Can you do that again? And the clinician, oh my, yes, of course I'll do that again. It helped you. It didn't seem to stick. It did seem like you reverted back. So, well, let's do it again. Let's do a little bit harder this time. Let's a little bit longer this time. Let's increase the intensity this time. Maybe if we just keep pushing against this wall, it'll go, and we get locked into this pattern of hope. And there's nothing wrong with that. We want to have hope. We want to help. We want to make this person feel better. And we did something that did that to a degree. And we just keep using the same technique and we plateau. And that's a common trap. And we easily convince ourselves, especially when we're newer, that if I just keep doing this, the patient will break through. And unfortunately, I hope you can learn faster than I learned. Oftentimes they don't. They plateau. And then they get discharged because insurance stopped paying. Point 3, a whole body evaluation is going to give you much different information than a pelvic evaluation. Now, intuitively, I hope that lands. Logistically, more complicated. But if all I ever do is look at a pelvis of my patient, I can gather vast information about the tissues and structures and innervations and movement and blood circulation of those structures of the pelvis. And I can do a lot of things. But if I haven't seen what's going on in the rest of the body, I've missed a lot. Simple case, knee pain. How often is knee pain actually generated in the knee? Classic trap. Knee dysfunction is really, really often coming from a foot issue, dysfunction of some kind, a hip problem, a weakness perhaps, maybe the core. Knees are very rarely knees. Knees are often just symptoms for something else adjacent that is dysfunctional or not ideal. If I can give you an example, I had a series of people that came into me for pelvic floor dysfunction. And on my first session, I look at the pelvis. It's important. Right? We look under the hood. The patient needs me to know what's going on in their pelvis, and I do a proper pelvic evaluation, and I get some information. I find data. What are the tissues like? Fine. Depending on what we find there, I always tell my patient on visit 2, likely I'm not even going to look at your pelvis on purpose. Please don't be surprised. I need to make sure that your pelvis isn't just the victim, the thing getting bullied here because there's something else in your system that you are having to adapt to or compensate. Patients love this. They're like, oh yeah, a whole body approach. And they adore that. They love I'm spending the time to do that. And I'll tell you, there's been many cases where the actual dysfunction is somewhere not even close to where their symptoms are. Like, not even close. Very high up the chain, the neck, the jaw. Very low down the chain, a foot, a knee. And if all I did was look at the pelvis, and the only data I gathered was pelvis data, I would have missed all of that, wouldn't I? I have to look at the whole system. I can't just gather data about that one body part. It won't work. It's important to have a system, to have a strategy, to look at the whole body, to do that zoom out. Otherwise, we miss stuff. Okay, so plateaus happen. Guilty, not holier than thou, all the time. What do I do when I've got a pelvic floor case and they're plateauing? A couple of things. I need to have the humility to step back. If I keep doing the same thing over and over again and it's producing the same results, the person's plateauing and not getting any better, I must have the discipline and the willingness to take a step back and rethink. And that does take effort and work, mental gymnastics, successes and failures, but I have to take a step back. Now, what does that mean? Take a step back. I hope as a clinician, if you're watching this, you'll say, oh, yeah, of course. But take a step back to where? What do I do next? And I want to give you something, right? I promised we'd talk about some strategies. And so I want to give you something, the neurological background to what I will say is far out, super complex. But there's a couple of spots that I go to evaluate to see, have I missed something? And an interesting area that I go to a lot is the upper cervical spine. Now, what? The upper cervical spine? Did he just lose his mind? Like, why would I default to, ooh, pelvic case plateauing? You know what? Zoom out. Stop what you're doing. Don't just rinse and repeat. Let me go treasure hunting. An area I find a lot of treasure is the upper cervical spine. And that's wild. And the reason is the incredible complex neurology of the upper cervical spine and its direct manifestations through the rest of the body, including the pelvic floor. What's in the upper cervical spine? A lot. A lot. And that's why it's a good place to go hunting. You've got nuclei of nerves that are responsible for your parasympathetic nervous system, your sympathetic nervous system, your ability to feel in your face, in your jaw, in your eye, your ability to scan the horizon, see the visual field, which, by the way, your nervous system prioritizes over almost everything else. Safety. The upper cervical spine dysfunction can cause direct problems, lack of rotation, threat. It can cause overactive signaling into some critical pieces of the nervous system that ultimately govern our parasympathetic and our sympathetic chains. Dysfunction in the upper cervical spine is a crisis for the body. Crisis. Let me ask you, how many people have you seen, pelvic or otherwise? How many people do you know, patients or otherwise, who have a dysfunctional, non-optimal cervical spine? Uh-oh. A lot? I bet that's your answer. That's my answer. A lot? Uh, most? Right? Like Yonda told us about this, I don't know, 1,000 years ago. Upper cross syndrome, forward head posture, shortened, overactive suboccipital muscles, lengthened deep cervical flexors, suboccipital nerves going haywire from compression and hypoxia. We've known this for a long time. It's the link between the commonality between this upper cervical spine dysfunction and manifestation in the pelvic floor. So I just invite you, if you're plateauing, just take a look, do a screen, see what you can find. And shockingly, more times than not, if you're plateauing, you're going to find something worth finding. You're going to treat something worth treating. Plateaus. You felt it. It's tough. It's tough as a clinician, huh? You feel like you're in a rut, you're doing your best, you don't know what to do next. And I just want to tell you that there is a system for this, and it's teachable. Now, I put together a free training, Why Pelvic Floor Treatments Fail, even when you're doing everything right. And I would love for you to check that video out to get a bit deeper into this. Thanks for listening.